Okay, well, welcome everybody. This is our National Social Anxiety Center quarterly webinar. Today, we're going to be learning about cognitive behavioral group therapy for social anxiety. And I'll start by just telling you a little bit about our speaker today. So we're excited to have Julie Watashik here with us today. She's a clinical psychology doctoral fellow, finishing her PhD at Eastern Michigan University. She has a master's degree in clinical psychology and in health services administration, and she spent the first part of her career focused on improving healthcare in various program and operational leadership positions in a variety of healthcare settings, including managed care, hospital operations, and community mental health. In the last 5 years, she has focused on improving care directly as a clinician and researcher, with a primary interest in anxiety disorders, developing specific expertise in social anxiety. Her current research is focused on the development, implementation, and evaluation of innovative interventions, such as a brief intensive version of CBGT for social anxiety. We're very excited to have her here with us today, and she'll be talking for about the first 45 minutes or so, and then we'll have 10 to 15 minutes for questions at the end. Feel free, if you all want, to go ahead and put questions in the chat as she goes, and then we'll just get to them at the end. Awesome. So I will now pass it over to Julie.
All right. Thank you so much for the invitation to present on this topic. This is an area that I am truly passionate about, so really appreciate the opportunity to be here with all of you today. So this is what I'm going to cover. I'm just going to give some background information on cognitive behavioral group therapy, just so everyone's on the same page. Then I'm going to talk about our most recent critical review and kind of the results from that. And then I'll just summarize kind of what we're seeing in terms of strengths and opportunities. All right. So most of you know this, I'm sure, but cognitive behavioral therapy is still the current gold standard treatment for social anxiety disorder. So we see, not only the group format, the individual format, combination of both. Research has shown, and perhaps those of you that currently run groups may have also found these benefits. Really, the benefits of group are that participants can engage in exposures together. They can learn from one another. There's a normalization of symptoms, kind of that sense of belonging and mutual support, and also increased accountability to complete their homework assignments. It can be a lot more cost effective. We have lower rates for group therapy, so sometimes that can make it more accessible for participants. So for those not as familiar with the current research results in terms of efficacy, it has been shown to be effective, not only in reducing social anxiety symptoms, but also common comorbidity symptoms, and actually improving patients' overall functioning and quality of life, which I'll talk more about. So there was a meta-analysis in 2016 of CBGT randomized waitlist control trials found moderate to large effect sizes for change in social anxiety symptoms and also general psychopathology, so depression and general anxiety. Found that CBGT was superior to treatment utilizing, those common factors in the reduction of social anxiety symptoms, but not overall psychopathology, so didn't overperform in that area. And then it was found to be equivalent to individual therapy and pharmacotherapy. So studies evaluating change in quality of life are definitely less common. And again, I'll talk more about that, but there have been several recent studies that found significant pre to post improvement in this area. Similarly, change in functioning is not something that is measured as frequently. But again, there have been some recent studies that have evaluated this factor and found a significant improvement for those that have participated in cognitive behavioral group therapy. Also finding that changes in social functioning may be predicted by those changes in social anxiety or depression symptoms. So SAD treatment research has included the identification of moderators, mediators, and mechanisms of change. So why does this matter? Well, because these factors can impact treatment response for our patients and clients, and it can help explain how this change in outcome occurs through treatment. So, for instance, different individual studies found that factors such as the gender of participants, level of their perfectionism, and level of functional impairment and or readiness for change could moderate or impact the magnitude of change that could occur through this form of treatment. Keeping in mind, though, there was a review in 2023, so combining multiple studies that found that only the severity of symptoms and the fear of negative evaluation moderated outcomes. And this was, across multiple studies. So in terms of mediators, several studies have also attempted to explain how the change in outcome occurs. So helps to explain the relationship, again, between the treatment and the outcomes. So potential mediators of successful treatment outcomes include reductions in self-focused attention, anticipatory processing, and post-event processing, as well as changes in perceived social cost. And then also have found decreases in fear of negative evaluation as a factor that kind of helps explain that change. So in terms of a mechanism, so in other words, that underlying process that explains, how that mediator, for instance, operates, proposed mechanisms of change include the three processes here, the first three bullets. So cognitive reappraisal, so where we have individuals kind of change their interpretations of events as part of cognitive restructuring. Also decentering, so where we have clients de-identify with their thoughts, and emotion regulation. So again, what does this mean for clinical practice? It means that those three processes in particular are probably important to focus on in terms of achieving success for our clients with treatment. Do keep in mind a couple of caveats. We want to be mindful that we're not sure in terms of the research base whether it's unique or shared mechanisms that impact the improvement of social anxiety symptoms, comorbid symptoms, quality of life changes in functioning, and also just further research is needed. A lot of this is based on, again, individual studies. Many of the current findings have not been replicated, so there's always more to do, but this is what we've learned so far. All right, so for those of you currently delivering treatment or already familiar with CBT, this is going to be a review, but just wanted to briefly mention these components in case there are folks joining or, will be watching the recording maybe that aren't as familiar. So I'll go through this very quickly. So SAD CBGT packages typically include these components. So there's some aspect of psychoeducation. So we're, talking about social anxiety symptoms, prevalence, describing the treatment process for our clients. We'll have a cognitive restructuring component. So we're helping them identify automatic thoughts, cognitive distortions, challenging those thoughts, or beginning to see, how to interpret them differently. And then, of course, we have exposure. So we're encouraging individuals to gradually engage with those feared situations, usually, in office or in vivo, out in real life, or through those homework assignments. Another aspect is behavioral experiments. So this often comes from the model proposed by Clark and Wells, where we're helping our clients do some experiments to test, are their predictions about a social situation actually true? And, help them learn that their predictions are not always true. Another common, I guess, more historical component that may or may not be included is social skills training. So really, this is if we see deficits, if there are deficits within our clients, then we're using this to target those deficits and increase social skills and just overall performance. So, despite the significant impacts on symptoms and overall functioning, it's estimated that only 50% of those who would meet criteria for a diagnosis of SAD seek treatment. So, very sad, very sad statistic. Again, for those of you that currently provide group therapy, you may recognize some of these barriers, but these are barriers frequently cited in the literature as well. So access to treatment, of course, lack of time for treatment, scheduling conflicts, cost. So even though, group sessions are, less expensive, it still adds up for clients. So sometimes that is still a barrier. Sometimes treatment's only available during school or work hours, and that's a barrier, or maybe at a location that's not convenient. So all sorts of barriers like that. And then also, overall, maybe clients are just not seeing progress quickly enough. So, that contributes to them, maybe dropping out. So this is, by the way, one reason I'm currently conducting a study on a brief intensive form, just to help clients maybe see that progress a little bit quicker and reduce attrition. So this is a little bit of an older statistic. However, I haven't really found any information to contradict this. Those of you that are viewing this may have some insight in terms of what you actually see in practice, but based on what we know, 1 in 4 participants are dropping out. So acceptability of the treatment is really an important factor in addressing this. So paying attention to these factors is something that's important in keeping our clients engaged in treatment. So how do they feel about the treatment? What's their overall attitude? Sometimes this has to do with what are their expectations? Does the treatment we're providing seem credible? What's the perceived burden or amount of effort that that's involved with the treatment? Does it align with their value system? Do they understand it? Do they understand how it works? What are their opportunity costs? What do they feel like they have to give up to participate? And again, perceived effectiveness. Are we telling them how effective this treatment is? And does that impact their perception? And then, what's their level of confidence? Do they actually think they can complete what is really required in terms of treatment? So again, all of these factors have a really important impact on whether our clients stay with us or not. So that was the overview. Now I'm going to get into the actual critical review and give you a sense of the results. So this is the citation for the review. So this was published in the Journal of Anxiety Disorders last year. All right, so research on cognitive behavioral group therapy for social anxiety has been ongoing for over 20 years, so quite some time actually, but we really still have a lot to learn. So the goals of this critical review were to summarize and evaluate the most current research to provide the field with an update on results. We looked at the overall methodological design quality of the studies. We wanted to provide recommendations for the enhancement of future studies. This presentation for all of you today is going to focus on providing a summary of the results. So this is kind of the criteria that we used to select the studies. So we looked at the most recent 5-year period at the time. So these were studies that were conducted between 2018 and 2023. So we identified 23 studies that met the following criteria. We used these databases. So they had to be published in a peer-reviewed journal in English language. These are strictly adult samples, so 18 years and up. So keeping that in mind, of course, patients or clients with social anxiety disorder. They had to use either cognitive behavioral group therapy or cognitive group therapy. And I'll talk a little bit as we get into the studies about, the difference, but really we felt like both of those applied and kind of fell under that same umbrella of studies that we were looking at, even though they're not exactly the same. If a study had an exclusive focus on online or app-based group therapy, those were not included. So just keep that in mind. There may be other studies, out there that had that focus. Also, book chapters, case studies, and unpublished manuscripts were not included. So that gives you a sense of kind of our selection criteria. So I'm going to now provide some highlights from the included studies over the next few slides, just to give you a sense of the results. What are the findings related to cognitive behavioral group therapy? So I've organized the studies by those that did not have comparison groups, and then those that did. So I'm going to cover those that did not have comparison groups first. And these studies on this slide and the next one used what I'm going to call a more traditional form of CBGT. And what I mean by that is they didn't try and enhance it in any way. And that'll probably make more sense when I get to the ones that did, because I'll be talking about, what those enhancements were. So basically, these were studies that were looking at different factors using that more traditional form of CBGT. So the first one, for instance, was looking at gender differences, and, did that impact response and treatment-seeking behavior and treatment dropout? I'm not going to cover these in detail, but the slides will be available for reference. So you'll have kind of, the additional detail if you're interested. But again, just to give you a flavor. So the next one was looking at long-term follow-up. Did we see that the effects were maintained almost like over 4.5 years later? And in this particular study, we did. The next two were focused on fear of negative evaluation. So in terms of moderation effects, and then the specific association with what they classified as our rapid responders. So those that really showed a very rapid response, there was an association with, a drop in fear of negative evaluation. The next one focused specifically on post-event processing. So, what are they thinking after a social interaction? So this was also identified as a mediator. And they found that this predicted lower symptom severity after treatment. And then the last study here specifically looked at decentering. So again, that was one of the mechanisms I listed, and they found that it predicted improvements in most of the outcomes that they looked at. All right, so the next two studies we're looking at social anxiety and depression. And so the first study found that changes in both predicted social functioning changes. And then the next study found that treatment that primarily targets social anxiety can lead to decreases in both social anxiety and depression symptoms if the client doesn't meet criteria for MDD, major depressive disorder. But if they do, then what they found is that an intervention that addressed kind of shared factors, so addressing both of those, would probably be better for those types of clients. And the last one on here is that group cognitive therapy. So basically, this study was focused around adapting the Clark and Wells cognitive therapy individual model into a group format, and they used it in a community outpatient setting. So again, this model, if you're not familiar, is more focused on behavioral experiments. And what they found is that it was effective for those with moderate to severe and even treatment-resistant social anxiety. So good to know there. Okay, now I'm going to get to the enhanced versions. So again, these are still studies without comparison groups, but they added something to our kind of traditional CBGT. So this first one was a telehealth group. So, that's basically the enhancement, is that it was a telehealth format. So they did report decreases in social anxiety and at least one secondary outcome. The second study here used something called imagery rescripting, and they found that it didn't yield significant additional reductions in social anxiety symptoms, but did show improvements in other areas. The studies in the next couple of slides are those that use comparison groups. So we're looking at, again, different kind of enhanced versions of CBGT. So the first one looked at imagery. It looked again at imagery enhanced treatment, both delivered in the setting where the treatment was developed and in a community setting, and found large effect sizes in both settings. So it didn't matter what setting it was offered, it was effective in both. The second study, also around an imagery enhanced version, they compared it to what they called a verbally enhanced version, and found that it did not demonstrate greater improvement. So again, if you're interested in these specific studies, I have the citations here. I also have a reference page at the end, which you'll be able to use to get more information about the details. This next study looked at motivational interviewing, and found that it doesn't appear to benefit, or sorry, it does appear to benefit those with social anxiety and high functional impairment, but actually may interfere with outcomes for those that are already higher in readiness for change. So it makes sense, right? And then the last one looked at a brief version of CBGT. So this was like a 6-week version, and compared it to a verbal exposure augmented cognitive behavioral therapy of kind of standard duration, and found significantly greater treatment effects with the brief version. So just an example of, yeah, a different format. Then there was a study that looked at adding something called psychodrama. So essentially, and certainly not an expert in this study, but basically looking at, adding a component where patients actually act something out. So they act it out instead of talking about it. That was essentially what that was about. Did not find any significant differences in outcome, though, from that. And then let's see. So there was also an enhanced version that looked at negative self imagery and demonstrated better results. And then the last one here used something called attention bias modification, and that did show greater reduction in social anxiety symptoms, and also at follow-up. So a couple of more here. So the next couple of studies compared, group therapy to, or compared CBGT to group therapy with non-specific or common factors. So more of that like supportive therapy. So what they found is social anxiety and ruminative thinking decreased. And then this was another study that looked at this brief version, so the 6-week version, and did find that it was superior to that supportive therapy at both post and follow-up. The last set of studies compared CBGT to mindfulness-based therapy groups. So in the first one, found that CBGT outperformed the mindfulness-based intervention in reducing both from a clinician perspective and a self-rated perspective, SAD symptoms. And then the second one looked at mindfulness-based stress reduction and compared that to CBGT, finding that they may both enhance clients' reappraisal and acceptance emotion regulation strategies. The last study compared group to individual therapy, finding both showed reduced social anxiety symptoms and were equally effective at reducing different comorbidity symptoms. All right, so I know that was, again, a lot of information about 23 different studies. The information will be available if you want to learn more, but I want to give you some more summary information about kind of this body of research. So you may wonder, for instance, what the patient samples looked like, and whether they were similar or different from what you typically see in your practice. So that's why I wanted to kind of give you a sense of, inclusion and exclusion criteria here. So primary diagnosis of social anxiety was part of the inclusion criteria for all but 3. The other 3, of course, social anxiety was a criteria. It just didn't have to be the primary diagnosis. So another common criteria was that the participant was either not on medication or was at least stable for a certain period so that that didn't, impact the results. So many of the studies excluded participants with high suicidality or self-harm risk, schizophrenia, psychosis, active substance use disorder, or bipolar disorder diagnosis. So just keep in mind, many of those comorbidities were excluded in terms of the studies. But really, the list of exclusions varied. So it is difficult to compare results, of course, or to conclude which specific comorbidities or other factors may or may not act as confounds. So we just have to keep that in mind. Also difficult to isolate the effects of the study treatment if the participants were engaged in some other form of treatment. So sometimes that was an exclusion if they were, if they had recently been engaged in another group therapy, but sometimes it wasn't. So, again, that's kind of an unknown variable sometimes. All right. So what does group therapy look like? And how might the studies compare to maybe what you're offering or considering offering? So the standard, according to Heimberg and Becker, is 12 weekly, 2.5-hour sessions. And really that was the most common format among the 23 studies. Keeping in mind, though, session structure did range. So I mentioned those brief versions. So those were, just 6 weekly sessions. And we did have a study that actually had 18 weekly sessions. So there definitely was some variation. Also, in terms of the duration, we saw like 1-hour sessions to 4-hour weekly sessions. So again, variation. And then we saw anywhere from no follow-up sessions after treatment to 3-month follow-up, 3-month follow-up session. So again, lots of variation. And then in terms of group size, so the recommendation, according to Heimberg and Becker, is 6 members. Often what we see, I think, is between 5 and 8 to be more of that ideal size. And within this body of research, participant numbers range from 4 to 11. So again, some quite a lot of variation. All right, so of course, part of assessing the quality of treatment was looking at the use of validated manuals. So studies did vary in terms of the level of detail that they provided on the manuals that they used, but most did indicate the use of some version of a well-validated manual. So for instance, these were the manuals that were cited most frequently. And actually, in the next slide, I have a full citations for these, so I will get to that in a moment. But for now, I've mentioned Heimberg and Becker a couple of times, so you'll notice there are a couple of variations in terms of years published that the studies use, but 13 out of the 23 did use some version of Heimberg and Becker. Clark and Wells, so again, there's some variation in terms of the version or the year of the manual or the protocol, but it was used in 8 of the studies, so also another, pretty frequent one. Rapey was used in 3 studies, and then Hoffman and Otto was used in 2 studies. So these were, again, the most common. However, 13 studies indicated developing protocols based on multiple validated manuals. So in other words, they indicated that they were using maybe one of these above and then combined it with some additional material that was either unique to their particular study or, maybe that they gleaned, from some other external source. But there was a lot of combining content, which is definitely understandable in terms of serving the particular study goals, but it does make it difficult because, again, we can't do a lot of comparing between the studies because they're using a lot of different manuals or different versions of manuals. All right, so I mentioned I would give some references here. So I'll just pause for a moment here, but these are those most common manuals. So if you are interested in starting a group or, getting some content, I recommend you start with one of these, I think, because they're just used quite frequently. All right, and I will move on. All right, so of course, various measures are used to identify change in research studies, but they're also an essential tool in support of measurement-based care and practice. So in other words, having some sort of objective measures to identify whether the treatment we're providing is working in a number of different areas can be really beneficial. So before I get into the various categories of measures, you may be curious as to how often measures were provided. So most studies, of course, measured, before treatment and then after treatment. That's kind of a given. But some measured in the middle. And those that measured in the middle were really looking to assess for trajectory of the treatment response. And sometimes they were looking at a particular aspect of treatment in the middle of treatment. Also, there was variation in terms of measurement afterward. So some measured following treatment like a month later or a couple of months later. And then I mentioned there was one study that really was interested in looking at long-term follow-up. So they actually, administered a number of measures 4.5 years later. So there was a lot of variation, but again, of course, most commonly before and after. So I'm going to go through some categories of measures first in the next couple of slides, and then following that, I'll actually, give you some very specific detailed information on, what these measures were, so you can get a sense of maybe what's being used. So the first one obviously is diagnostic assessment, which we're not always doing with clients in practice, but definitely helpful from a study perspective. So these are those semi-structured or structured interview instruments for that initial SAD diagnosis confirmation. And then, of course, we want to assess social anxiety symptoms. So there are both from a clinician perspective and from a self-report perspective. So I'll talk a little bit more about that when I get into the specific measures. And then we want to look at maintaining factors. So some of the measures, were specifically designed to look at the maintaining factors or moderators, mediators, or mechanisms. So essentially, secondary measures that were assessing changes in for specific aspects of social anxiety and really varied, depending on the study goals. Then there were a set of measures that studies used to assess comorbidities and also general psychopathology. So we're looking at things like depression, anxiety, and just a broader range of psychological issues, physical and emotional symptoms. So then there were also a smaller number of studies, but we're looking at overall functioning. Did that change? Did the participants' quality of life change? Did their overall well-being change? So really looking at these measures were specifically designed to measure those things. Then there were a set of measures that looked at just the participants' group therapy experience. So they were assessing aspects of group therapy like, what was the working alliance? What did the participants think about our working alliance? What was their overall client satisfaction? What was the cohesion like amongst the group? Treatment credibility and expectations at the beginning of treatment. And then also homework completion. Just because we know that that makes a difference in the outcomes. And then the last set of measures were around physiological measurement. So these are those objective measures using, things like heart rate, skin conductance. There was one study that did an fMRI. So definitely less common, but just gives us an additional piece of information, a very objective piece of information. So those were the general categories. I realize these tables are very busy, so you can go back to them at your leisure, but you at least have the information. So I have the categories of measures here on the left-hand side, and then the actual measures that were used. So I won't go through all of these, but just kind of to give you a basic sense here. So from a diagnostic perspective, for instance, 8 of the studies used the SCID, 7 used the ATIS, 7 used the MINI. In terms of assessing social anxiety symptoms, the most common assessment was the Leibowitz Social Anxiety Scale, 11 of the studies. And then, you'll see some other very common ones. So studies typically did not give a lot of detail in terms of why they used one measure over another. They often did provide the psychometrics, so they provided, some statistics on the validity and reliability of measures, which was great. But they really didn't say, why, for instance, I'm using the social phobia scale versus the social interaction anxiety scale. Some of these kind of have clearer distinctions in terms of, what they're looking at that is different from some of the others. So for instance, if you're looking at the social phobia anxiety inventory, it's assessing anxious feelings and somatic symptoms for social phobia and agoraphobia. So it allows kind of a distinction between those two. So if that's something, that someone's interested in identifying, that's a useful scale. Another example is the social phobia scale, so the SPS, and the social interaction anxiety scale. So these are often used together, and they're assessing for 2 different things. They're assessing the fear of being scrutinized and the cognitive, affective, and behavioral reactions to situations. So again, those are kind of used together. So yeah, and then the clinical global impression improvement scale is, assessing those social anxiety, the change in social anxiety severity from a clinician perspective. I'll highlight maybe one more on this page, which is in terms of instruments used for looking at maintaining factors, moderators, mediators, and mechanisms. You'll see that this brief fear of negative evaluation was used pretty frequently. So in 9 of the studies. The rest of these really were only used in one study each. So they were really looking at these specific variables depending on what the study goals were. And then in terms of comorbidities and general psychopathology, you can see the list here. So again, kind of the most common was the Beck depression inventory. So 8 studies were really looking at change in depression symptoms as well as change in social anxiety symptoms. The anxiety inventory was used in a couple of studies, and then the rest of these were used in one study each. So you can see kind of some assessments that are maybe broader spectrum in looking at, changes in psychological functioning from a number of different aspects. And then in terms of functioning or quality of life or well-being, again, this wasn't something that many of the studies looked at, but those that did, 2 of them used the quality of life inventory. And then you can see kind of the other assessment tools that were used by just one of the studies. So kind of a broad range. But looking at things like even, did the participants' self-esteem change? So a lot of different things. And then the last two types of measures, so there wasn't a very commonly used assessment tool to look at group therapy experience, but this also wasn't assessed very frequently among the studies. So you can see this is a list of some of the different assessment tools that were used. And then physiological measurement, I mentioned. There was a study that looked at heart rate variability, skin conductance, and then one that assessed using fMRI. All right, so again, if you're thinking of offering group therapy or already provide it, you may have some questions related to competence of group facilitators. So what did we see in this body of research? The high level answer is a lot of variation in terms of um, credentials, in terms of supervision, in terms of training. So this is what we saw. Most of the studies indicated that the group therapy was delivered by an experienced doctoral level psychologist and a combination of either doctoral or master's level supervised trainees and co-therapists. But you can see here in the second bullet, there was a lot of variation in terms of the credentials for the group facilitator. So, ranging from master's or doctoral level psychologists to very specific and a lot of experience in this last one here of doctoral level psychologists with 2 to 30 years of clinical experience and 2 to 25 years of experience as CBT therapists. So again, the take-home message is there's a lot of variation even amongst the studies. Same thing with training. So sometimes they didn't describe what kind of training the group facilitators had, but those that did said, some of them said like therapists received training on the treatment manuals and ongoing training, and that was, kind of it. And then there was one study that actually indicated Dr. Heimberg provided an additional training for the therapist. So, it ranged, and I would say that's not something maybe that was as important for some of the studies to get into. Same thing with supervision. There was a range. So for, some of the group therapy, there was a 1 hour weekly supervision with a licensed psychologist. Some got a little bit more specific and said weekly supervision with a licensed psychologist with expertise in SAD and over 20 years of CBT experience. So yeah, again, take home message for this entire slide is, yeah, there's a lot of variation. So in summary, strengths and opportunities of CBGT. So I talked about benefits in the beginning, and really, I think that's one of the key strengths of this form of group therapy is that participants can learn from one another, they can support one another. There's a tremendous benefit of this type of group therapy. I think the second thing is we have a lot of research already on how effective it is, and that's meaningful. So we know it works. We also have a lot of validated manuals. So many different versions to pick from that we know, have been validated by many different studies. So we have a lot of great resources to guide our treatment. And similarly, there are a lot of measures that we have to assess outcomes. So I think those are kind of the strengths here based on the findings. So what are the opportunities? Well, member recruitment, I didn't mention that yet, but I'm sure those of you that, have offered group therapy or want to provide group therapy, and I can say in my own experience, this is true. It's tough, right? It's tough to recruit group members. And so that is definitely, something it remains challenging, as well as retention. I talked about attrition. it's tough to keep people engaged, especially for 12-week period. It is tough to keep people engaged. So finding new ways to do that is an ongoing opportunity. The second one here is, I mentioned this, but I'm just going to reinforce it. We need to confirm some of these moderators, mediators, and mechanisms through further research. So we need to, keep doing the research and find ways to incorporate those things into our treatment if they aren't already, because those are the things that we know are effective or that make treatment effective. So I talked about we have a lot of great validated manuals, but what we don't have, or maybe not enough of, is so which specific manuals are most effective and in what scenarios and when and with what types of clients. That's an opportunity, I think, to learn more about. That's not something I think we know enough about. So definitely an opportunity. Um, and then kind of similarly, we have a lot of measures, um, but it doesn't seem like we have full consensus around, which measures to use for what type of population and in what scenarios. So always have more to learn there as well. So those are really the most or the most significant opportunities. So another thing that I didn't mention on the slide, but I think is really important to keep in mind is we also looked at kind of the diversity of the samples, and as you might expect, they weren't very diverse. So um, one of the benefits, I guess, of the 23 studies is that they were conducted in a lot of different countries. So we have the benefit of knowing that this form of therapy is effective with, people in different countries, but the within country samples themselves were not diverse. So again, uh, strengths and opportunities there. But I think just continuing to build on, more diverse samples and kind of incorporating any cultural considerations in our group facilitation materials is also going to be helpful. And with that, this is the reference page that I promised. So this QR code you can just scan, and it will give you all of the references that were used in this presentation. So with that, I want to see if there are any questions from folks that I can answer.
Awesome. Yeah, thank you so much, Julie. That was fantastic. So we had a couple questions come through in the chat, and perhaps we can start with those, and then folks feel free to put more questions in the chat or raise your hand and we can take questions live. One of the questions in the chat was for the moderators. This came in back when you had your moderators and mediators slide. I think you mentioned that fear of negative evaluation was a moderator of outcome. And the question was it more severe symptoms and more severe fear of negative evaluation or less severe?
All right. So
Yeah,
sorry,
the
ask the
fourth,
last part of the question now that
yeah,
I've slid back up.
it's the fourth bullet point under moderators.
Yeah.
Just what was the direction of the moderation?
Oh,
Was more
severity of
severe,
symptoms.
yeah, was more severe symptoms associated with worse outcomes or with better outcomes?
So, so the greater severity, I think the less effective.
Hmm.
Um, yeah. And then fear of negative evaluation. The more change that we saw in fear of negative evaluation, the greater the change in SAD symptoms as well.
Got it. That makes sense.
So
Okay.
yeah, I think basically, in terms of the severity, it's probably not surprising. Like, if we see kind of those more severe cases of social anxiety, the treatment is still effective, but just maybe less so than, the cases where it's kind of more mild, moderate. And, there was a study, there was one study that specifically looked at, I think it was also depression, but, there are some studies that are actually looking at that. Like, what does make it more effective if we have clients and patients that do exhibit that higher level of severity of symptoms?
Yeah, that makes a lot of sense. So wasn't that also a predictor of attrition?
Yes, I believe it was.
That makes sense, right? Being in for somebody with more severe social anxiety, being in a group is going to be like a 10 out of 10 exposure, I could imagine.
Absolutely. Absolutely. I think it's yeah. Yeah, I mean, I've seen it in, anecdotally in my own groups. So yeah, absolutely. It's tough when you have that varying severity level within that same group to kind of tailor treatment to meet the needs of kind of that spectrum.
Right, right.
Yeah.
Sense. One more follow-up or a couple more questions that came through. One that says, oh, this was when you were talking about some of the enhancements
Yeah.
of the different studies that you reviewed. One of the questions is, could you briefly explain what the imagery enhancement and negative self-imagery modification interventions might look like?
Yeah, so I will definitely refer you to those studies in particular, because I am not an expert in any one individual study for sure. But so essentially, when we're talking about those imagery enhanced versions, it's really trying to tap into having the participant actually, like visually like create a visual representation of this social interaction and what they think will occur.
Mm.
So it's kind of envisioning it beforehand and kind of like mapping that out in their mind in terms of what they think is going to occur, what they predict will occur. But yes, certainly go to the study and read the details of that.
And I think you said you were open to sharing your slides with us, right? So I can also, for
For
those who are
sure.
attending, I can send those around as well so that you'll have the full reference list.
Yeah, for sure.
Awesome.
For sure.
And one other question, were there studies or were/are there studies or controlled studies with online group CBT for social anxiety disorder? And I think you mentioned one online study or one telehealth study.
One telehealth study.
Yeah.
Yeah, and actually, so we specifically excluded those studies that were exclusively focused on online, and actually none of the studies that we ended up including had like an online component. So there certainly are studies out in the research base as I was, kind of searching through those. They definitely do exist. They just weren't part of these 23 studies.
And what would be the difference? I think sometimes I might use the words interchangeably between telehealth and online. What would be the difference between like a telehealth group versus an online group?
Yeah, so good point. So this particular group, you're right. It was online, but it was very much facilitator. The facilitators were actually thoroughly involved in each of the sessions versus if we had an online version that was more self-directed and participants. So I think that maybe, yeah, that's the difference maybe that I need to clarify is that it's really, were there facilitators that were involved, that were leading the sessions, that were, directing the activities during the session, or were they more of an online kind of self-directed um, type of approach?
Got it. That makes a lot of sense.
Yeah.
Great. I know we have a few more minutes left. Do other folks have any questions, any additional questions? You can pop it in the chat or raise your hand. And Julie, while we're waiting, I have a question. I'm curious if you can tell us a little bit more about what your brief group your group CBGT intervention will be for social anxiety.
It's a mouthful, right? Yeah. Yes, I would love to tell you about it.
Awesome.
So this group that we're going to be running is a brief intensive version. It's specifically for emerging adults. So between the ages of 18 and 29, we're targeting specifically. And we're looking to condense. So, I mentioned the kind of standard format of therapy is more that 12-week, 2.5 hour, duration. And we're looking to condense that into either 2 days over a weekend. So a full day Saturday and Sunday, or half day Saturday and Sunday for 2 consecutive weekends. It could also occur during the week, but based on the feedback we've received so far, it will likely occur during a weekend. There are other models where this is starting to be offered, so this brief intensive version. So, this is not entirely brand new. There are other models both for social anxiety and also, for other anxiety disorders where, they're seeing a lot of success. So we want to build on those successful models, and it's basically an acceptability and feasibility study. So I'll be excited to see what our findings are. I am very optimistic that we will see fantastic results. We're looking at, all of those, many of the different areas of measures that I mentioned. So we're going to be looking at, did social anxiety change? Did, depression change? Did their quality of life change? All of those sorts of things. So hopefully at some point I'll be excited to share with you all of the findings.
Yeah, we'll have to have you back to come tell us all about the results of that.
I would love to. Love to.
Awesome. Any other questions before we wrap up? I know a few folks have to hop off for clients and patients. Okay. Well, great. Well, if folks do have questions, feel free to send them to me and I can always pass them along to Julie. And Julie, thank you so much for being here today. It was wonderful to have you, and we really appreciate you coming and talking to our group and providing all this excellent information. And we look forward to hearing how everything goes with your study from here.
Happy to be here. Thanks so much.
Awesome. Bye, everybody.